compensation.
Okay, thanks a lot. First of all, the problem being the last speaker in such a session is that you have already seen all the slides. So the good thing is that it will be a nice repetition, and hopefully after having heard all the presentations, you will understand it even better than just following one or two presentations. So my task is to discuss the implications of new findings and how does this translate in current treatment, either recommendations or new treatment studies. Okay, good. So that is the current treatment algorithm for advanced GIST from the European expert community. Okay. So this is advanced metastatic GIST. The first-line therapy in imatinib-sensitive mutations, and I can only repeat what both of the previous speakers already pointed out very clearly. The mutational status is a must-know. That's not something you may have or not. Without the knowledge of the mutational status, you cannot give a solid recommendation. So a patient with a metastatic GIST with an unknown mutational status cannot be treated correctly. The mutational status has to be established in 100%. There is absolutely no exclusion from that. That is very clear. So in imatinib-sensitive GIST, the first-line treatment is imatinib at a dose of 400 milligrams for most mutations. We, not all experts, but we strongly recommend 800 milligrams in case of an exon 9 mutation. Second-line treatment. Second line always means the first line either fails at a given time point. That may be 2 years, that may be 10 years. So either failure of the current treatment line or intolerant side effects. That's the two reasons why we would consider changing the treatment. The second line standard of care is sunitinib. Again, in case of failure or intolerance, the third line currently is regorafenib, and the fourth line currently is ripretinib. So that is the current algorithm: imatinib, sunitinib, regorafenib, ripretinib. Outside of a clinical study, this algorithm has to be followed. There is no exclusion from this algorithm on anything outside of a clinical study. In case of a PDGF receptor alpha D842V mutation, avapritinib is the standard of care. In any treatment line, the recommendation, of course, is to use this in first line because no other currently available drug is active in this situation. So it does not make any sense to use anything else apart from avapritinib. We still do see patients who have had some sort of pre-treatment, which never works. So then they receive avapritinib in whatever line. But as soon as such a patient enters an expert site, avapritinib is the treatment recommendation. Currently, there is no further treatment option. If a patient fails avapritinib, there is no further treatment. And it has been shown that the prognosis of these patients is extremely poor. Secondary resistance to avapritinib leads to death within weeks or a few months. There is no other chance at this moment. There are a few extremely rare special situations, which Eva already pointed out, NTRK and other mutations, also the SDH deficient. They are not part of this treatment algorithm. So that's the standard line for imatinib-sensitive mutations, and avapritinib is the recommendation for PDGF receptor alpha D842V. In US, it's recommended for any PDGF receptor alpha exon 18 mutation. In Europe, it's only labeled for D842V, which is how many percent of the exon 18? 80, 90, 70. Okay. Good. So that is the starting point. This, just very briefly, is a study nearly 10 years old now, which we did in the situation where sunitinib was the only available second-line therapy. And I just show this to point out that it's beneficial to keep a patient on the current treatment if there is no rapid progression, if the patient is tolerating the treatment well. We do call this treatment beyond progression. That means the radiologist tells you the lesions have grown by 7 millimeters, 1.5 centimeter. The patient is tolerating the treatment well. The patient is feeling well, does not have any problems, does not have pain, symptoms, anything from the GIST. In such a situation, the recommendation is to continue the current treatment and not change. We only change if there is a need to change. And a need to change is given when the patient develops symptoms, the GIST is growing, causing problems, pain, whatever. Then we change. If there are no problems, the only problem is the radiology report telling you 1 more centimeter per lesion. That is not a reason to change treatment. This applies to all lines of treatment, not only to second-line sunitinib. This applies to third-line regorafenib, and it has also been nicely shown to apply in fourth-line ripretinib. So treatment beyond progression is something to keep in mind. We do see patients who are hurrying through the lines. Imatinib a year, then there is a little bit of problems. Okay, second line, a little bit of problems. Third line, bad tolerance. Fourth line, again problems. And then the patients are at the end of the algorithm at a very short time point, and there is nothing behind. Therefore, try to get the best of any line. Maximum first line, maximum second line, maximum third line, maximum fourth line, because then you start having a problem. So that's the second general issue. 2 studies have tried to challenge this current algorithm. The first study was challenging the third line, comparing avapritinib to regorafenib in third line, patients having failed imatinib and sunitinib. The comparison was a randomized phase 3 study. Half of the patient received avapritinib, the other half regorafenib. The hope was that avapritinib would be better in third line than regorafenib, and the result from the study was the opposite. There was no statistical difference. The red curve is regorafenib, so it seems to be a little bit better, but again, not statistically. So both drugs are equally active in third line, which means that regorafenib remains the third line standard of care. The next study challenging the treatment algorithm was the INTRIGUE study, already mentioned. This was done in second line, patients having failed imatinib only. They were randomized to either receive the second line standard of care, sunitinib, or ripretinib, the current standard of care in fourth line. And again, the hope was that ripretinib would be even better in second line compared to the promising results in fourth line. However, the result did show that there is no significant difference in second line. The curves are completely overlapping, which means sunitinib remains the standard of care in second line. So neither of these two studies did change the current algorithm, which remains imatinib 1, sunitinib 2, regorafenib 3, ripretinib 4. That's the current standard in April 2024. So, trying to make it very easy to understand the resistance mutation scenario. Because the question is, how can we improve? We start, that's 60-something, 70%. The most frequent primary mutation is an exon 11 mutation. Secondary resistance mutations are either exon 13 or 14 or exon 17, 18. Of course, there are a few more, as Eva already pointed out, but that covers the majority of clinical situations. So what are the possible scenarios? The possible scenarios are primary mutation exon 11, secondary resistance, which means the GIST is growing in the presence of imatinib. So the patient is taking imatinib and the GIST starts to grow. One explanation is there is a secondary resistance mutation in exon 13 or 14. Second possible scenario. Again, GIST is growing with imatinib. The second scenario is that there is a secondary resistance mutation in exon 17. Third possible scenario, primary exon 11, part of the tumor cells develop a secondary resistance mutation in exons 13 or 14, and the other half of the tumor cells develop a resistance mutation in exon 17. Taking a biopsy does not help. Eva has shown a 1 square millimeter biopsy containing 3 different resistance mutations. So imagine the patient has 10 liver lesions, 200 peritoneal lesions. Whatever you biopsy will never show you what the overall situation is. So taking a biopsy is completely useless, does not help. Liquid biopsy is very promising because the idea is that what you take or what you get in the blood is a result of the overall mixture. So in this situation, in the blood, you will find the exon 11, the exon 13, and the exon 17. But as Eva pointed out correctly, that is not yet standard of care. So outside of a clinical study, we do not recommend taking a liquid biopsy because we still do not know which recommendation to base on the finding. So in routine treatment, liquid biopsy does not play a role in April 2024. So how to deal with these situations? I go back. In this situation, we already know that the best drug in this situation is sunitinib. Sunitinib is the most potent drug in secondary exon 13 mutations. So if this would be the overall explanation, this patient would respond in 100%. In this situation, we know that sunitinib is completely useless. does not have any activity in exon 17. So here we need another drug. One of the best drugs in exon 17 is ripretinib. Also, regorafenib has activity in exon 17 and experimental agents. So in this situation, the current standard second line will fail. That's the patients who progress on imatinib, go on second line sunitinib, and progress within the next 1, 2, 3 weeks. And then move on to third line, regorafenib, and have a reasonable chance to respond because regorafenib covers the exon 17. In this situation, currently, there is no drug available that will solve the problem. We currently do not have a drug available that works really good in exon 13 and exon 17. That's the problem. So what are possible solutions? This has been mentioned already, the PEAK study. I just made it very clear we currently do not have a drug that covers all the resistance mutations, the most probable ones 13, 17. So if we do not have a single drug to cover these two, the idea is we take the best drug to cover this one and combine it with the best drug to cover that one. In order, the combination covers everything. That's the idea. And that's what takes place in the PEAK study. That's the combination of sunitinib plus a new drug called bezuclastinib. Bezuclastinib, simply speaking, has been developed to specifically inhibit exon 17. So we do combine the best possible exon 13 inhibitor with a very good exon 17 inhibitor. So the combo will cover all. That's the idea. And the comparison is the standard of care in second line, which is sunitinib. So the patients are randomized to sunitinib plus bezuclastinib combo. And the comparison, the other half of the patients receive the standard of care, sunitinib alone. This study is still actively recruiting. The expectation is that recruitment will probably be completed in Q3 or Q4 this year. That's the current expectation. And this trial may change the second line in the future. If this study is positive and proves that the combo is superior to sunitinib alone in second line, this may become a potential standard of care for second line therapy. But this remains to be seen. Another option is if we don't have a drug that covers all, we can try to identify patients who benefit best with an available treatment. So we do know there is nothing for all, but we have drugs available. So we try to identify patients who benefit best with an available treatment option. This again is the INTRIGUE study, second line, ripretinib compared to sunitinib, no difference for the overall population. That's why sunitinib is still the second line standard of care. However, in this study, liquid biopsy was done and the results were very interesting and really striking. That is a so-called forest plot because well, this one not really, but it looks sort of like a tree with all the branches. So what you can see here is there is this line going down to 0. So anything going as big to the right as to the left doesn't make any difference. Anything going far left or far right is a big advantage for either this or that. So we look at the outliers, and there are two striking outliers. One is this. As you can see, that's far from the 0 line. It's over there to the right. That is favoring sunitinib. So what is that? That is the patients with exon 11 plus exon 13. My first resistance scenario, 11 plus 13, that's the ideal patient for sunitinib alone. There is nothing better than sunitinib for these patients at the moment. There is another outlier, even more striking, because that is very far to the left. It's very far from the 0 line. That's these patients. Let's take a look. That's the exon 11 plus 17, 18 only. That's the second scenario. These patients by far favor, or this situation favors ripretinib. So these patients benefit excellently from ripretinib compared to sunitinib, whereas these patients benefit by far more from sunitinib than from ripretinib. All the rest is more or less not so big difference. So we can now take patients with a clear identification and offer them a specific treatment. That is showing the curves, the survival probability, progression-free survival probability. It's the same in a different presentation. Here we do see that's the 11-13 group. Sunitinib is much better than regorafenib, than ripretinib, sorry. Sunitinib, ripretinib, 11-13. Even more striking is the second scenario. That's the 11-17. Ripretinib, sunitinib. As you can see, sunitinib in this group is completely inactive. Within a very few months, all the patients progress. That's just not the drug for these GIST cases. Whereas ripretinib is strikingly active. That's a so-called waterfall plot. For good reason, it looks like a waterfall. Everything that falls down is good because that is tumor shrinkage. And everything going up, growing in this situation is bad because growing for a tumor is always bad. And you can see the 11-13 group, ripretinib has some activity, but a lot of growth, whereas sunitinib, apart from one single patient, all the GIST tumors shrink. Opposite, 11-17, wonderful waterfall plot for ripretinib. All patients benefit. There is no patient with a real progressive disease. A little bit of growth, but not enough to qualify for progressive disease, whereas sunitinib does not have any efficacy. So very clearly, with the liquid biopsy, we can identify a group that is very likely to have a substantial benefit from being treated with ripretinib in the second line. So now we could say that is the recommendation. However, as you know, there needs to be proof from a prospective randomized study. We cannot say, well, this is all very logic and we are convinced that it's correct. We still have to do the study. And this study will be done, has already been started, not everywhere in the world, but in some parts, and it will hopefully complete fast. That is the situation. Based on the fact that we have a very, very high expectation that the study will be positive, the only thing we can do to make it a little bit better acceptable for the patients is to use an unbalanced randomization, a 2-to-1 randomization. So the patient has a double chance to get the expectedly better arm, and only 1/3, unfortunately, goes to the expectedly inferior arm. Now, as we know, the target population are patients with the 11-17 scenario. So we are looking for patients in second line who have failed imatinib. They will be offered participation in this study called INSIGHT. And if the patient accepts, then we will take a liquid biopsy. And if the patient has the scenario 11-17, no 13, only 11-17, then this patient can enter the study, will be randomized to either receive sunitinib as the current standard of care, or ripretinib, which is the experimental arm in this study. And again, 2-to-1. The number of patients to be put on this study is extremely small. Why is the number so small? The bigger the difference you expect, the smaller the study can be. If you are looking for a difference of 5%, you need thousands of patients. This is only possible in breast cancer. So in breast cancer, we have studies that show a significant superiority by 1.8%. You would never be able to prove superiority in such a small margin in a study that has less than 10,000 patients per arm. Here we expect a dramatic difference, and based on statistical calculations, this means that we only need to put 54 patients on this study. 36 will receive ripretinib, and 18 will receive sunitinib, obviously with a crossover. And the population is the exon 11-17. Now, how many patients do we expect in the second line? For exclusive 11-17, the current expectation is 1 out of 7. So we will test 7 patients, and we will find 1 out of these 7 who has this 11-17 only scenario. The other 6 will have 11-13 or a mixture. The majority has a mixture. They cannot go on this study. We only look for exclusively 11-17, 1 out of 7, and they will very likely show the same results as from the retrospective study. And if this is the case, then we would have, in case of a positive study, we would have a new standard of care in second line for the liquid biopsy proven 11-17 only subgroup. Markus?
Normally, somewhere that which you have face, that only the was automatically let's introduce.
Yeah.
Probably.
Yeah. That's absolutely necessary. As we see 54 patients for a global study in, I don't know how many sites globally, more than 100 sites to identify 54 patients. In Germany, we have the two most experienced sites for GIST studies, and that's Sebastian Bauer in Essen and myself in Berlin. No other sites. Why? It does not make sense to open 10 German sites, and 8 of them will very likely never include a patient. So we decided, we as the company and the investigators, that it's better to have a small number of sites and the patients should be referred there. So if there is a German patient in a second-line situation, the recommendation once the study is open will be the patient should be offered to be sent to Essen or Berlin, checked for the study. 6 out of 7 will be sent back, and the 1 out of 7 will stay in either Essen or Berlin and put on the study. That's the concept. And so we very strongly ask all German sites to send their patients so we can screen them and identify the 1 out of 7 that fits the study. Eva?
Normally we do not look at secondary rotations, and I would say for years and years we said we will not make any analysis on secondary rotations.
Yeah.
Because now it changed. At least, I mean, what do you think realistically? How many patients do you have to screen? You said 1 out of 7. So you have, if Germany wants to include 10 patients or so, you would have to screen 17 or
And screen means it has to work. Liquid biopsy doesn't work in all. So we can only put patients on the study who do have a clear result 11, 17. Those who have no real output from the liquid biopsy analysis, they cannot go on the study. So that is a potential risk. But if we do identify this small subgroup, then they can go on the study.
17 mutation. The tissue sample?
No.
Because this makes a bias.
Yeah, because the tissue sample shows that in the sample, it's 11, 17. In 10 other samples, it may be 11, 17. And in another 10 samples, it may be 11, 13.
That all secondary mutant cells are shedded into the blood, which is just an assumption.
To be clear, I do not think that this is the case, because I think we know that it's not the case. The only thing is, we do need a method to identify patients who can go on a study. There is probably a percentage of patients who have 11, 17, but it's not identified with liquid biopsy. Liquid biopsy may also fail. We may have patients with exon 11, 13 and 11, 17, where liquid biopsy doesn't work properly and it comes out 11, 17. So they will go on the study and fail. So there is a risk, but at least it's a way to try to identify patients. And if the study will be positive, which is what we all expect, then it will be a combination. The test has been done by a specific technique, and those who have the result tested with this specific test, they can either go on the study or will receive this treatment as a standard of care once the study has been completed and positive.
Second mutation or so.
Again. Yes. Exactly. Okay. So, third is to look for new drugs that work in all the scenarios, 1113 and 1117. I already said currently there is none available, but there is one drug that might be working in this situation, at least better than what we currently have. That's also, again, already mentioned, a drug called IDRX42. That is the activity over the mutational spectrum. The lower, the less drug you need, the higher, the more drug you need. So everything down there is very actively addressed. So this drug covers basically all exon 11 primary mutations, part of the exon 13, not so good 14, but at least a bit, and a number of 17s. This drug is probably, we have only limited experience so far. There's an ongoing phase 1 study, extremely well tolerated. So we will probably reach blood levels in this range. And that means that we may be able to inhibit 11, 13, 14, and 17 in the vast majority of specific cases. That's the current hope assumption. And the ongoing phase 1 study, which means we are still looking at the optimal dose. It has not yet been identified. We're still increasing the dose, is called Strategist. Also in a small number of sites around the globe. So, in brief summary, secondary mutations are complex. So we have 3 possible ways to address the point. One is based on the fact that we don't have a drug currently available that addresses all secondary mutations, that we use a combination of drugs, one that covers this and another one that covers that scenario. Second possibility, we have a given drug and we try to identify the patients that fit to the drug. And the third one is we have the patients and we try to find a drug that fits to the patient. That could be this new drug, IDRX42, still under development. So that's the current situation. And we hope that ideally all 3 concepts will work. We'll see. The PEAK study is well underway, should be completed by the end of the year. The INSIGHT study is already underway, not yet in all countries, but in a number of countries. We hope that it will recruit fast. And the third, the drug is still in phase 1 dose finding, also recruiting nicely. So in the not so far future, we might have a change in the current algorithm. Thank you.